Get ready to crack the code to better health. Join us on the Crackin Backs Podcast with Dr. Jason Amstutz, where we uncover the secrets to unlocking peak performance, relieving chronic pain, and enhancing your musculoskeletal health. Discover groundbreaking techniques that blend chiropractic, osteopathy, and advanced soft tissue treatments. Don't miss this exclusive conversation with Dr. Amstutz as we delve into the science of biomechanical dysfunctions, the power of cryogenics, SomaTherapy's fluid flow magic, ELDOAs for joint health, and the synergy between osteopathic principles and traditional chiropractic practices. Whether you're an athlete or just seeking a healthier, pain-free life, this podcast is your ultimate guide to a better you.
All right, our man from Philly. Well, born and raised in Philly. I have to start with that after we started. Dr. Jason, I gotta, when I was kind of looking you up and all that, I got fascinated because you use a combination of chiropractic and osteopathy, which is, at first, when I first went to chiropractic, it's called the osteopaths were the enemy, and now they're just freaking awesome. But you did a combination of both and advanced soft tissue treatments in your practice. What the kind of thing I want to kick off to get listeners engaged right off the bat is what are the traditional methods and what's unique benefit to the athletes and the non-athletes by using these different combinations.
Well, I mean, if I may, do a little historical touch in. I'll be brief. The whole chiropractic osteopathy thing, I didn't realize until maybe 12 or 13 years ago, in my ignorance, that it was really about potentially Palmer taking a look at the body after being in class with Andrew Still, right? And one person says potato, the other says potato. One says the rule of the artery is absolute, and the other said, no, it's the nerve. And this old traditional osteopathy that's mainly alive in Europe and Canada, who I stumbled across a really phenomenal one in 2011. I mean, the answer to your question is the chiropractic construct is an incredible one, but it's not the complete package of the physiology and histology of the body. And you can talk about joint mechanics and how those things are different, or we can talk about the physiological effects of, I don't know, breathing or whatever, all these things that have like these individual components around sports chiropractic in particular, and how they all really are kind of summarized and what's the proper word? Utilized in these traditional osteopathic ways. And it's a dying art and thing. Chiropractic has actually taken a bigger stronghold in all of these European countries where traditional osteopathy is still alive, which I think is really interesting because I think, again, it's a piece of the puzzle, but it's not the broad spectrum. So more specifically to your question, I think the number one thing is the manipulation of the fluid dynamics of the body. And, step one, osteopathy was the old hemodynamics. You got to have blood, the rule of the artery, things that we're all familiar with. Like that's what the other side was doing, right? Oh, Andrew Still, he was crazy. You got to have blood everywhere. It's like, I don't know how crazy that is, but okay. And then it became more of the fascial understanding, both anatomically and physiologically. And the rest of our body is all some fluid, the whole entire thing. So when it comes to like the immediate acute injury and or the chronic ones that seem to be resurfacing with professional athletes and non-professionals, I think we start with the proper movement of the fluid in the joint. And the synovial fluid specifically changes its thixotropy, which is, is a big word, but it's just really the viscosity can change depending on the amount of agitation or movement. This is a very simple thing from ketchup and from paint. If you don't stir the paint, you can't put it on the wall. If you don't stir the synovial fluid will become an impedance to the ankle movement long before it's a quote unquote subluxation or the bone doesn't move. Now, not in a traumatic sense. The talus goes anterior because they got hit in a certain way or planted or whatever. That's great. Maybe the synovial fluid was never affected. However, post injury, even post adjustment, if we're not careful, that starts this ebb more toward a gel or a solid and away from the really slippery, viscous thing that we all study exists in that synovial joint, which is paramount for proper function. So it's this marriage between the bone has to function exactly how we all learn it. There's no hesitation in that. The people that aren't on board with manipulation and or joint biomechanics because potentially they have a different licensure, I mean, hey, that's okay too. But I mean, we all know that you got to start there. So that piece of the puzzle doesn't change, Doc. But I think this understanding of this fluidity, we call it, of the actual joint and the related joints in the chain, that potentially matters just as much as whether or not that talus is anterior.
How do you identify, joint, if you call them fixations or biomechanical dysfunctions? How are you identifying them?
So, I mean, we're going to talk about an extremity because it's easier. The ankle,
yeah.
for instance.
Either way, yeah.
I mean, yeah, because there's another can of worms behind that, which maybe we'll touch on. We'll stick with the ankle. This pumping technique, this osteoarticular pumping, which has been a construct of modern day osteopathy around the world for a long time. It's a lot of general osteopathic pumping, depending on what you're familiar with osteopathy. But my mentor, Guy Voyer, took it to, the nth level, at the level that I teach the pumping in the United States, which is all first year therapy stuff that I teach. It's, I don't know, 300-400 different pumping techniques, first specific to the joint and every bone, pretty much in all the directions that we kind of conceptually understand. But it's this more fluidic dynamic model involving both the ligaments and the fluid. Because once you get outside of the joint, now the ligaments play a role in this spring-like effect or whatever it is. It's not just a rope, right? The quality of the ligament on just on the outside, called the capsule, and just outside of that, pick your ATFL or whatever you like. These things all have to function as a complicated fluid dynamic system. So to answer your question specifically, it's this pumping really becomes, Doc, after you practice it a little bit, you start being able to feel the difference between one ankle, maybe anatomically and structurally is sound because you adjusted it yesterday or you adjusted it today or somebody else adjusted it. But this whole like squishy, this kind of like gray area of, is there a little bit of space? And is there this like ability for this joint to really breathe with this fluid? Because the fluid in the ankle, especially the mortise joint and the subtalar, that is the anti-compressive nature of the joint. You better not be riding on your hyaline cartilage surface of your tibia on your talus, or you'll destroy your talus. Mm-hmm. And we see that in sports all the time. Hard ground sports, basketball courts, NFL, because of the power and the forces, you got to have that fluid cushion in there. That's what's anti-compressive at the talus. So hopefully that answers the question.
So, okay, you want to take an ankle, you got 150 different ways to move an ankle, let's say, but
totally.
How, are you comparing it to the other ankle? Are you comparing it to a standard in your head? How do you know it's hypermobile or hypomobile?
I think the hypomobile is, we're talking about either end maybe of a spectrum, right? So from the hypomobile thing, the first thing that goes is does it have this liquid kind of feeling to it? Is it free? Is the whole thing free and the talus is still out of place? That's a different feeling ankle than the one where the guy sprained it or the woman sprained it 6 other times since 2010. And that one feels like not only is the talus and the thing stiff, but the whole thing, number one, it looks a little more swollen than the other side. It's like, oh yeah, the fluid never went away in that thing. It's still healing. I'm like, when was the last time you cut yourself? How long did it take to heal? 16 days? Okay, you don't have a healing problem. You got a thixotropic ankle fluid dynamic problem. And so comparing it to the other side, if you're lucky, the other side's normal, right? Depends on what sport,
Yeah.
right? And if you don't have that, you really develop this other sense of this micro movement. Like if we talk about a mechanical thing, I speak a lot about the micro movement of the joint. The micro movement of the talus in this case would be plantar flexion. The talus slides anteriorly, does a little bit of an internal rotation, and goes down on the facet of the calcaneus, right? Like those are the micro pieces of that system, if you will. And then when you go into dorsiflexion, it sure as heck better move posteriorly and do the anti of that, the reverse of that, so it can hide, so the ankle can dorsiflex properly. So sometimes you can make these things happen because they're loaded or because, oh yeah, it kind of works or moves. And it's really not a joint fixation anymore, but it still doesn't feel right. And this is when you get into this gray area of the fluid. There's got to be something with the fluid. We're not talking about blood. I'm not talking about there's too much venous, there's not enough venous return and you got to just, that's a different problem, right? Like that has to be accounted for too. You got to be able to tell the difference. But a lot of these older chronic injuries, I believe, show up in the office as not only more of a joint fixation, but also the fluid. If the fluid is not constantly moving, it gets thicker because it stagnates and pools there. And then it's harder to get out. It's harder to change the fluid to go out. And that's a big piece.
Is that when you talk about pumping the joint?
Yeah, you're pumping the joint to change. So the pumping of the joint from a basic fundamental understanding is I'm creating a bigger volume, which drops the pressure slightly. Mm-hmm. And then I'm starting to oscillate that. I let it go, and then it increases the pressure. Well, it's this change in pressure that will ultimately change the fluid dynamics in the joint. And part of that fluid dynamics is not only to move it, but to also change the viscosity. And if you do that, I mean, this is where it's a lot different. Mm-hmm. Sometimes with some of these chronic ankles, if that's the big thing, maybe I have to do whatever technique 100, 150 times. But you'll change it right on the table.
So different,
both the look and the feel.
Different than HVLA or high velocity, low amplitude manipulation. You're talking about gentle pumping and certain directions?
Yeah, depending on which way the bone needs to move, similar to an adjustment mindset. Or first and foremost is you got to have space and you have to have fluid. So the number one place in the ankle is you sure as heck better have space between the talus and the tibia. Mm-hmm. And the fluid that's in there, if it's not already squeezed out because you got an x-ray and the whole thing's compressed together, that doesn't mean it's gone. That means that space needs to be returned. Mm-hmm. And then hopefully the liquid fills in the difference. Now you have a protected talus from the tibia banging on it over and over. And that's when we see what? Compression fractures, bony edema and changes in young athletes, and they start destroying their talus.
High ankle sprains.
High ankle sprain, that's a big mechanism, right? The talus turns so much, it wedges the tibia and fibula from each other, injures the ligaments involved, but very early, like the next day, you can pump the joint. And then for some of us, right, you can also adjust that talus the next day after that too, which helps with this process of the body naturally moving the fluids. Because you don't need to be pumped to have proper fluid movement. You just need the proper joint biomechanics and use the joint. That's the normal way.
Guy comes in with a knee or hip. Are you going to check the ankle first, or maybe, or secondarily?
Great question.
What are you going to do?
I mean, in this particular osteopathy, and you talk about joint biomechanics and fluid dynamics in the same conversation, it all starts with the pelvis. Because all of the chains of the ankle and foot end up at the ilium or the sacrum. So if the ilium and the sacrum aren't doing their micro movement, micro dance, you can have a downstream fluid problem, let alone a biomechanical one. And yes, those are related, obviously, right? But I want to bring them apart just for this conversation. So, but that doesn't mean I don't check the foot and ankle. Anybody that, if you read enough books and you understand enough, you've been around, it's like, okay, obviously the big toe's got to function, the ankle's got to move correctly for sure. But if they have a bigger problem at their pelvis and they came into me for a knee or a hip, I put more stock in the pelvis day one.
Interesting. I really appreciate Dr. Terry. I got to tell you, man, selfishly, these are things that we've learned. And when we talk to people like Dr. Jason, it resurrects all this. Like, of course, sometimes we're
Right.
off in different directions, and that's a beautiful thing to recall or remember. So I have
agree.
I have a challenge. Well, it's been a challenge. It's since been fixed, but there was a NFL referee that his whole world was running backwards, and he ended up what appeared like every once in a while he got this zapping pain in his ankle because what I determined was that the talus would subluxate or would be in the wrong place at the wrong time, just ever so slightly, and he would be like jolted at the worst times, during during refereeing an NFL game.
Right.
So at what point now I'm thinking hypermobility? How would you have approached a situation like that? Or am I not giving you enough data?
I mean, it's just, that's a tough question because of the data thing. But we'll just assume for a second, we'll just take it down right to the ankle. I mean, yeah, the talus is notoriously has to move anterior underneath these forces, whether you're running backwards or running forward, because full plantar flexion, the talus slides forward. I think one of the biggest challenges through this methodology is we don't spend enough time on the anterior restraints, which are the tendons, anteromalleolar, the ones that are in front of the malleolus. They don't get enough attention. We have so much retromalleolar strength and tension, posterior tib, flexor hallucis, soleus, Achilles, gastrocs, versus the extensor digitorum, the extensor hallucis longus, the peroneus brevis. No, those are retro. I mean, that's really kind of it. Peroneus tertius. If they have a peroneus tertius, which is in 14% of the people, then they have an extra anterior restraint to the talus going forward. So what I have found, since we're all chiropractors, let's assume we know how to put it posteriorly and we're on to the next thing. In those cases, we actually shorten and the tib anterior. We shorten all of the mechanisms anteriorly to provide the next level of restraint in front of the talus and the capsule and the blah, 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 to help balance out whether or not that thing has more of a bias to go forward. Like maybe what you're describing is you kick it a little more or it pinches in the back because now it moved too far forward. But I think very quickly our hands need to be off of them and they need to be helping discern this tensegrity puzzle, which is part fluid dynamics and part tension relationships and things of that nature.
So how would you approach supporting all the anterior support tendons? I mean, what would
we
you
shorten them, and we use those. If this is my ankle, and I want to do my tib anterior, and I do, your normal dorsiflexion under resistance is full range. The problem with that is, if we're talking about a bad talus position over and over dynamically, you don't want it to be able to go so far forward. So then you do what we call the internal range of train. You can train a muscle in a couple of different ways. You can train it in its full range. The joint goes through its full range of motion, no problem. That's good for most joints and most tissue. Sometimes you want the muscle to only be worked at the end range closer to its longest because you have a tendon problem. That we call that the external range. I'm currently dealing with a patellofemoral kind of fat pad issue, quad tendon articularis genu problem. And all of my knee extensions, I only do from max flexion to halfway to put a lot more stress on my tendon. We call that the external range. That's good if you need to lengthen something while you're strengthening it. Rec fem is always notorious for that.
Okay, back to the ankle, because I want to be clear on something.
Sorry. Okay, so I was just describing the ranges of motion. Sorry. And then you have the internal one, which is you're at max contraction, dorsiflexion in this case, and only go halfway the other way. And if you do that over time, you'll actually shorten the tendon and shorten the complex. That's advantageous in many places. And for this talus anterior potentially doing it too much because they run backward all the time, maybe that's part of the strategy for all those muscles I mentioned. You shorten them a little bit to help better restrain the talus.
I want to get crystal clear. This is your ankle. This is the front. And you're talking about dorsiflexion. But if you want to strengthen the anterior tendons,
if you want to shorten the anterior tendons, yes. Shorten.
Okay. You're going from which way? From here to here?
From maximum dorsiflexion to only halfway into plantar flexion.
So just
That will bias over time. You shorten from periosteum, tendon, aponeurosis, tendon, periosteum. And that is advantageous in a lot of cases, Doc. And I think that's a big overlooked concept that the hamstrings need to be shorter, quote unquote, in a lot of people because of all the anterior pelvic tilt problems. Same thing. You got the quads dominating anteriorly. You got the hamstrings that get 3 sets of 10 if you're lucky. And over time you get this big wound up pelvis. Well, you can stretch the front all you want, but you might also consider shortening some of these other things potentially. The abs is another one. Sometimes your abs need to be short in an athlete, not long, to help fight against that anterior gravity line, anterior pelvic tilt, whatever we want to call it.
Okay. You said hamstrings. I gotta ask you.
Uh-oh.
All right, hamstring strains because of overextension. So you want to shorten them, or am I not being fair with asking?
Well, I mean, I think for this discussion, I think we got to go back to the deep constructs. Like I'm really trying to hone this talk for next week specifically. You gotta understand the pelvis first. If these guys are running around with an out flare, we call it an osteopathy, and it's the same thing in Gonstead talk as an anterior ilium, an what is that? AIEX or IN? AI. That's with the rotation, right? You know what I'm trying to say, right?
Yeah.
If I take the ilium and I rotate it anteriorly, my ischial tube on that side goes further from the ground.
Right.
Now I've preloaded my hamstring. That negates all conversations in my head of how do you prevent the injury? Are they overstretching it? It's like, well, if the pelvis is stuck in that bad position, you're going to keep blowing it.
Right.
So that's the hardest part, because a lot of times we're intervening with other licensed professionals, right? As part of our team. And it's like, hey, well, the hamstring is this or that. It's like, okay, that's great. But what's the pelvis doing underneath? Because that matters more. Sorry, that's the master. And it's not because I'm a chiropractor. That's just the master, because that's the deep-seated problem. You can't work your way around that, in my opinion. You can try.
Yeah, I love it. All right.
That's an interesting, the hamstring thing and injury prevention, right? Like that's where I think a lot of this stuff can really have an impact.
Well, I definitely speak your language on the hamstring thing, because I'm always conscientious about where that ischium is in relation to the other side.
Right.
Okay, question. Okay, I'm moving off of that now. Let me ask you. I could actually stay on that a little bit more.
Can we stay on it for less than 60 seconds?
Hell yeah.
Okay. I'd like to add this part to it too. I think the difference in the tendon physiology, distal tendon versus proximal tendon, is totally different. And I think that happens because we train too much knee flexion and we don't make the superior tendon more robust by using the pelvis as the movable piece and not the tibia. So in this paradigm, we anchor the knee like you would almost like a what's that new exercise that's caught on so much? The Nordic. You guys know what I'm talking about?
Explain the one.
That's the one where you're kneeling and your feet are locked in, and I'm on my knees and my ankles are locked.
God,
the Nordic.
That's
Okay,
hard.
so if you do the Nordic in the way that they ask you to do it, you're still overloading the distal tendon. We never tear our distal tendon because of exercises like that and all the hamstring curls. However, if you took that same exercise and you just loaded it a little bit with leaning forward, but then you took my pelvis and you made the athlete move from the pelvis without moving the knee, now you are more accentuating the proximal tendon. That's how you make a more robust proximal tendon, which is where all these tears are.
Okay. Hold on.
Sorry.
You're right. I've got like 3 patients I'm dealing with that right now. I'm sticking needles up there. I mean, in their hamstring.
Right. Close to their butt. Yeah. Exactly.
Yeah. You know, right? I mean, I'm trying to.
He's in Florida, you know.
Yeah.
Right. That's permissible.
I think this show just went X-rated. All right. So let me. Okay. So what would be like, they got that thing called the butt blaster. They're on all fours and the foot is, they're facing that.
Yep.
And they're pushing up, but more femur and pelvis, more femur and ischium movement. With that's going to focus more on the, no?
If is the knee bent or the knee straight?
Bent.
The knee's bent, then you're going to get more glute max than you're going to get hamstring. I mean, in my opinion, not that you're not going to use the proximal ham. That's why we do RDLs, right? We do an RDL because we're trying to load more of the hip flexor mechanism for the hamstring. But the problem with that exercise compared to what I'm describing is if anybody said just move your pelvis while you're doing an RDL, everybody in the gym would throw you out. Yeah. Because it doesn't look good for your back. So but the whole but this concept, I mean, this is the concept is if I want to move more with the proximal tendon, I fix the bottom piece and I move from the top piece. And if I do the opposite, I lay down face down on a leg curl machine. Now I fix my pelvis automatically. My pelvis doesn't move. And then I do a knee flexion exercise that uses and makes a more robust distal tendon, which is great. But you have to do the same math for the upper one.
Wow. Of course. That is
right.
Yeah. Can we have
it's crazy. This guy, I mean, not only is he the world's foremost anatomist and fascial expert, but he also, more than any other osteopath in history that I've ever heard of, he teaches 2 years of exercise in his osteopathy program. If you can't reinforce these things that we're doing with our hands on a daily basis and you're throwing them out to the wolves, have you really helped them? They got to come to your table again next week.
I can't wait to do this. Can't wait to get.
Too bad we're doing the upper limb next week.
Maybe we could change it. Brenda,
you want me to change it? I get to change everything already.
we'll buy you dinner. We can do a private
right.
lecture.
I gotcha.
All right. Let me ask you about if you could shed some light on manipulating. Tell me about this gamma bias of muscle fibers, and if you could.
The gamma bias stuff.
Yeah. Tell me about that.
So who I originally learned that from is that really smart DC out of Toronto. Like there's so many of them, but this one in particular, he's from Estonia, and he started Trigenics. Okay. You guys know who I'm talking about? I can't believe I can't remember his name. I feel really bad. He's like one of my early mentors before I even got out of chiropractic school.
Is this one of the machines that
No machine. All hands-on manipulation based on motor points in muscle. So it's part acupuncture with your hands. But the gamma bias is the potential resting tension or tone of the muscle at rest. You can't be at a zero. You got to be measuring on an EMG or you'd be a pile on the floor.
Dead man.
Right. Yeah. Well, you'd just be a puddle. You wouldn't necessarily have to be dead, but you couldn't get up. You know what I mean? You'd have to be like, oh, I'm going to get up now. Now I'm going to fire this and go erect. So this resting muscle tension or tone, the gamma bias, is a big part of injury. And this is when we see an ankle injury. And if you don't try to reactivate all of these separate pieces in the Trigenics model, or for us more globally, if you don't turn the dimmer switch back on for those things that got shut off because I injured my Achilles or I injured my plantar fascia, there's a whole new program that goes into walking now. Don't hurt this. Don't walk this way because it hurts. That turns down all the dimmer switches. Now I went from a 50, whatever, some made up number, down to a 10 or a 20. I can still walk and ambulate and do things, but now I'm lifting my ankle too soon on my whatever. If you don't reprogram that as part of their rehab, the dimmer switch is still off, and they'll pass every motor test or every pattern test. What's the proper terminology I'm looking for, guys? These screenings, these movement screens.
Movement screens, yeah.
They'll pass the movement screen all day long. And yeah, these guys can pass the movement screens after the first time you showed it to them. Right? Like you did the movement screen on them. I had a guy from the Falcons a long time ago, and we got to talking, and he's like, oh, the second time I went in there, I was no better, but I aced the test. Right? Like those guys can cheat the system after 1 or 2 reps.
Yeah.
So anyway, the gamma bias is a big piece of making sure you reset all the dimmer switches back to their proper. So then you can really go through your rehab and not have any, inhibition, because you get muscle inhibition, right? Whether it's from a joint injury, arthrogenic, or one from your back, but also just a movement pattern that was once detrimental to their high ankle sprain is now safe.
Go back to the tone.
Tone.
Tone. When is there? We can feel, texture in a muscle. We call it spasm, and at rest. But how are you referring to tone and managing?
I'm talking on the upper echelons of function, right? Like this isn't going to be something the guy's dragging his toe because the muscle's turned off, right? That's the other end. This end potentially, in the Trigenics way, they do just a manual muscle test just to see if the thing's fully engaged and if the timing's good and stuff like that. But from a more functional perspective, I think, and if you can't see it really in a movement screen, you really just go back to repatterning the movement like the day after the injury in the pool, completely unweighted, and you have them go through a regular walking, striding, running thing, no matter what their injury, because that way the program gets messed up for a day or two, but you just retrain the whole neuroplastic problem that happens as a cascade effect of an injury. And I learned all that stuff from this really smart athletic trainer out of Philly, Bill Knowles, who has been using the pool as his main modality for injury prevention and fixing injuries for like 30 plus years. His whole construct is every injury that ends up, whether it's a surgery or on our table, is a physical, mechanical problem. But at the same time, at the same place, you also have an injury to your brain. In essence, I'm not talking a head injury, I'm talking about your ankle, that changes the way they walk. And if you wait until the end of rehab to reestablish this, because now they're finally running after 6 months, you just missed 5 months and 30 days that you could have restored that the day after they had ACL surgery.
There's a paper out there that this is an appropriate time to bring it up. There was a paper done where they did MRIs of the brain to see what activities were going on, what areas of the brain were highlighted pre ACL surgery and post ACL surgery. So what they found was that all the limping and all the compensating that you were doing, nursing this injury while you're trying to walk or run, remap the brain so deeply that even post-surgery, you were still showing the altered gait.
Doc, those guys end up back on the field cleared from the ortho.
Yeah.
With that kind of programming. So Bill Knowles talked about that study. And then he also talked about another one, which I think is really interesting, and only just for mention in this conversation. That's another ACL paper that they had showed the upregulation of the eyes post ACL injury, because now the person has to look around to make sure they don't mess up their knee. So you do that to a football player, you train them in the gym, their knee's totally fine, you're doing all this. He goes out to catch his first pass and he goes to look at the ball and doesn't look at his knee. And guess what happens? He loses all proprioceptive awareness of his limb and he re-tears. That's some really interesting stuff, right? That's some really interesting stuff.
Yeah. Oh, I love when they start looking at all these other things other than the injury itself.
Right.
Isn't that fascinating? Thanks for sharing that, because
no problem. I thought I was like blown away. This guy's lecture alone, I was just like, wow, there's another whole world of not understanding out there. And the papers and the research are just catching up to what he's been doing for 30 years. That's one of the most powerful things about because he's just been doing it anecdotally, and nobody wants to hear about experience. Everybody wants to hear about research. It's like, well, guess what? The research comes, 20, 30 years after 20 other people already discovered the same thing in their lab with their patient or in the gym or whatever, It's not the other way around. I hope you're not waiting for that bus.
Is there anything that you would do, I mean, in particular that you learned in restoring mapping of the brain after an ACL, let's say an ACL or whatever, an ankle?
Whatever, anything lower limb, hip, knee, ankle, foot. Yeah, I mean, this deep water running with a floated athlete, I mean, you go right back to redeveloping that motor program literally the day after surgery. You got to know what you're doing. I mean, you got to be able to understand wound dressing and all these things. Everybody shouldn't run out and do it, but conceptually, that's the kind of place we are. If we're in charge of post-surgical athletes, which some of us are, not everybody is, or if you're part of a team that is responsible for that, I think you got to really look at that neuroplastic change to get those newfound bad programs out of there as quickly as possible. And you can apply that to any limb or any injury.
What about without a pool? What would you do?
Yeah. Without the pool?
Yeah. Would you do a balance pad or a Bosu ball?
No, you'd have to work. I'm just talking about simple gait.
Right, of course.
I'm just talking about walking. But the problem is, if you hurt your ankle bad enough, it doesn't matter how much you want to wish to do it on day one. If you're not in the pool and he puts his foot on the ground, it's going to hurt and there's going to be a compensation. That's why potentially I haven't come up with a way where the same thing applies outside of the pool, Doc.
Oh, although they got that zero gravity treadmill. I forget what they call that thing that's worth $1 billion.
$50,000 or whatever.
Yeah.
Yeah. I mean, that could be, it's okay, but it's really, if you've ever used it, I've had one in some other facilities where I've worked, they're hanging you from a diaper from your pelvis. You know what I mean? And if we're going to talk about the pelvis, you can't be hanging me from a diaper.
I got it.
Now, can you take the ankle through a similar range of motion? Yeah. Now you start monkeying with the puppeteer up there, who's the pelvis.
Right.
So,
yeah, it's funny.
That's my only thing with that.
Makes sense.
The pool is a big challenge, but it's also, I'm telling you, you get into the pool and you need to learn from this guy. It's like revolutionary.
It's great. But I want to learn.
It makes sense, right? It makes sense.
I want to learn from you about SomaTherapy. Tell me.
SomaTherapy. Okay, so my mentor Guy Voyer has had his own osteopathy schools in places like Toronto, and he still has one in Montreal. So he gets brought over 20 years ago or 21 years ago by some really advanced trainers in this country. They hear about this weird French guy who's doing these exercises mainly to improve the space in the disc. And this is what potentially he's the most well known for around the world right now. ELDOA, ELDOA. Have you guys heard about that before?
Just from you.
Okay. So it's basically these exercises where you put tension to open up L5 or to open up L4 or to open up L3, fill in the blank. So somebody finds out about him, and I'm not sure exactly who it was, and it probably doesn't matter for this conversation. And they're like, hey, we need to get this crazy French guy from Montreal to come down and teach us some of this weird exercise that he's doing that is supposedly really helping take better care of bulging discs and myofascial stretching and accounting for all the fiber directions and all of this stuff. So they bring him in the United States. He starts teaching a couple of classes in like hotel lobbies and stuff like that, like, total cowboy style, which is awesome.
Yeah.
And it starts to build enough awareness in this country where then doctors of chiropractic in particular, two of the big ones, Keith Pine and Mark Lindsay, hear about this guy and they're like, hey, we got to learn more of like this exercise stuff is incredible. We want to learn more about your hands-on approach and what you're doing differently. So instead of going to Montreal for 7 years and going through his entire osteopathy program, he plants 2 little pods in the United States. One program, the Soma Training, which is 14 courses of his exercise, which I recommend to any chiropractor listening. And that's a whole nother realm of training and looking at the body. And then he also had another spinoff, which is 13 courses of therapy hands-on. And that's what I'm teaching now in the United States. I started in 2016. So it's the first year's pumping, 3 courses. The next year's fascial treatment, specifically to the ones that we can treat, get your hands literally on. 3rd year is this tendon and ligamentous manipulation. And then the 4th year is treating the 4 principal diaphragms of the body, which starts with the thoracic diaphragm treatment, then the cervicothoracic diaphragm treatment, pelvic diaphragm treatment, and then finally is the cranial vault, the cranial because that's a diaphragm too, a very sophisticated one. So in 2010, those same gentlemen wanted to know what everything that he knew about concussion, because fluid dynamics of the joint and the hip is one thing, but if you start to understand and apply this fluid dynamic concept to the brain, to the problems of post-concussion problems, now you're really onto something. So then they asked him, hey, we'd like you to teach us all you know about concussion. He said, how many years do you have? And then part of that was these 13 courses just to get your feet wet and really understanding the fluid dynamics of the brain.
Say his name again.
Guy Voyer.
Oh, I was pronouncing it like a gringo. Guy Voyer.
That's all right.
Sorry.
That works too. Yeah, whatever.
Guy Voyer.
I don't think he cares. French don't care if you call him a voyeur,
Voyer. Guy Voyer. So I want to, but I read something about self decoaptation. Am I saying that right? Tell me, what is that?
Self-decoaptation. That's the ELDOA. So that's the Americanized version name for that ELDOA concept, which is opening up the joint, opening up between L4 and L5, or opening up the hip, or opening up the AC joint, or opening up the glenohumeral joint, or any of the ones where you, the patient, can open it up yourself. I mean, these are some fundamental things. Now you don't need a set of hands, or if you do and you only see somebody once a week, they spend the other 6 days doing these ELDOAs, this self-decoaptation. They're creating their own space and fluid and flow on their own time, which makes it more permanent.
Wow. What do you think about motion palpation?
I think
it sounds like you're kind of doing some of that, no?
Yeah. I mean, I think motion palpation, that was Leonard Fay stuff, correct?
Yeah. And
is that right?
And another Frenchman, Gillet.
Oh, and Gillet, who wrote those papers that we read when we were in chiropractic school.
Right.
So if I'm not mistaken, Leonard Fay studied with some osteopaths also. Probably so, right? Like, for sure. So anyway, motion palpation, of course, you got to be able to, we and osteopaths and other people, you got to understand the constructs of how the joints move. If you're missing that piece, you can do whatever you want to the glute max and the hamstring and whatever else, but that is the fundamental. That is fundamental, as we say.
Yeah.
The joint movement is fundamental.
Wow. That's a lot of juicy stuff.
All right, I got to jump in on something, even though, I'm like sitting back and enjoying this, listening to this about osteopaths, is actually, thank you, because it's given me a whole new light about osteopaths. It seems like lately they've gone into the world of regenerative medicine, and they're all about injecting now and doing stuff like that. And it sounds like they've lost some of the history of the art, what made them great, and they've fallen into this regenerative medicine. What's your thoughts on
Well, I
that?
mean, you're talking about a different osteopath. You're talking about a DO in this country, which is they long lost their way when they got brought in underneath the MD. We got shamed and all of the rest of it, right? Our history. And then they took the stepchild and invited them into their camp.
Mm-hmm.
And so they're great. Yes, some of them have a little bit of a different mind based on where they went to school, but that's all becoming extinct.
Yeah.
Like what used to be the big school of manipulation in the DO program in this country was University of Michigan, or Michigan State, I forget which one. And now if you're lucky to have a DO, they still manipulate. But so I'm talking, no, so a long time ago, all this education and all of this traditional stuff was only, again, Canada, Europe, and different parts of Japan and New Zealand and Australia, where they recognize that we're talking all the same language, chiropractors and these types of osteopaths. The type of osteopath that you're talking about, they hang out with MDs and they do injections, and that's really awesome, but they don't have the understanding of the biomechanics. They didn't even get any of that.
It is fascinating. Ever since like you can go to a DO that's a gynecologist now.
Right, exactly.
It's just.
Yeah, that's a different DO. That's a doctor of osteopathy. All these other DO programs around the world, England, France, and Germany, where maybe the best ones in the world are, and Canada, they're a diploma of osteopathy.
Oh, interesting.
Yeah. I mean, that's just a semantics thing. But I mean, even in my studies, if I decide to write my thesis, which I hopefully will after all these years and all this money and time, and defend it, then it would be a diploma of osteopathy. It would never even it doesn't even register in this country. Wow. It doesn't mean anything. So I mean,
Have you learned osteopathic maneuvers versus
all the osteopathic maneuvers, Doc, are all chiropractic? You never. There's no difference. Now, when you talk about this pumping, because that's an osteopathic construct now, yes, that's different. That looks and feels different. But the HVLA and the manipulation is exactly the same.
I love it. Oh my God.
That's cool.
Yeah. There's some different people that came up with some different techniques, but no different than we have a bunch of awesome adjusters and minds in our profession that have different ways of, wow, I never knew I could adjust an navicular like that. And you're like, then you do that the rest of your career. You're like, that's the greatest thing I've ever seen.
Right.
Right.
Right. But I always heard, osteopaths, they do the long lever, mobilization thing. That's from like 100 years ago.
It depends on which camp. Yes. If they were part of a different, tree of influence, yeah, there's more of them that did more long lever maneuvers, or they do this, or they just do mobilizations. Yeah, this is like this osteopathy that we're involved in is like some old school chiropractic and some new school fascial anatomy and fluid dynamics, and that is a perfect marriage in sports.
That is great. I love it.
Yeah,
that's good.
Terrific.
So we're at a point where we love this section that we're going to go into. It's called the rapid fire questions. I think you'll handle it quite well because you seem to be quick on your feet. And some of the questions have absolutely nothing to do with nothing, but you'll have an answer.
Oh, okay. Perfect.
And
make something up?
Yep. Based on the theme rapid fire, your answer should be somewhat at least a sentence or two, but then we end up going off on a tangent anyway. So if you're ready, I got 5 of them for you. Are you ready?
I'm ready. I'm ready.
Dr. Jason, question number 1. When you travel, what is the one thing you always have with you?
My EMF canceling device.
Oh, that was good. Is it a wallet? Is it
okay?
Did you hear that? You guys froze for a second.
Oh, is it a wallet? Is it what is?
I have a.
Just happen to have it on me right now, right?
Buddy, always. This is from a company called Aries Tech. I've had one of these for, I don't know, 7 or 8 years, and it changes because now there's 5G.
Yes.
The old ones just blocked 4G and just help manipulate 4G. So
Yeah.
that's my number one travel thing.
Ooh, good one. See how we go off on a tangent?
Now, does that affect your credit? It doesn't affect credit cards or anything like that, does
No,
it? When you
no,
put it in your
not at
wallet?
all.
No, his testicles. He keeps
Yeah.
it near his
It
testicles.
protects. That's where it should be. That's right. You want to castrate a society? You bombard the testicles with 5G. That'll sterilize everybody.
And I put my phone right next to my in my front pocket too.
Perfect.
Beautiful, right? I already have kids. I don't have to worry.
Yeah, exactly. Me too. So I'm a little less.
Yeah.
I wear it around my neck now,
Yeah,
not around my balls.
Yeah, good idea. Oh, that was beautiful. Question number 2. Question number 2, you're traveling. What is your wake up good morning routine?
What is my wake up good morning routine? I drink a liter of water on an empty stomach. Highest quality water I can get my hands on when I travel, which is sometimes hard.
Yeah.
And then I go through a little quick 4-minute warm up to get the heat going in my body. And I do 4 or 5 ELDOAs, self decoaptation stretches in the morning, first thing when I get out of bed.
I want to see what those are when we get together in Vegas. I want to see. Is there a particular water you drink?
It depends on the application, but the cleaner, more ancient aquifer-based water that you can get your hands on, non-plastic, matters. I mean, it depends on who you talk to. I have a French mentor. So, the first 4 on the top of my head are all French waters. That's no mystery, but there's plenty of good water in this country. Mountain Valley Springs seems to test out really well out of Arkansas. And there's some others, but I mean, that's the most important vital nutrient that we ignore. Everybody wants to talk about organic foods and this and that, and that's all well and good and grass fed. And I'm on board with all of that. But if you're drinking shitty water, like, come on.
So Perrier?
No, Perrier's got fake bubbles. Perrier, that's manufactured bubbles. If you put manufactured carbonation into water, it drops the acidity to like 2.3.
Oh, for God's sake.
You might as well drink a Coca-Cola.
I'm a big club soda drinker.
Was it Fiji?
I'm going to get hammered.
I mean, hey, Fiji's great. That's a great one. It comes in plastic. That's not, but hey, that's a really good aquifer. That's volcanically filtered and it gets the energy and the minerals from that. That's good. That's definitely good. There's better, but that's good.
All right. Question number 3. What is the one thing you wish you had learned earlier in your career?
Earlier in my career.
Ooh, I think we got him.
I think this fluid model, this dynamic fluid model of the body, I think that needs to be in schools. Like, this isn't rocket science. This is how every body walks around. Like, where's the 80% water when the kid's born? There's not swimming pools of it in there. It's in the tissue. It's in the collagen tube. It's in the extracellular matrix. It's in the blood. The water's in the blood and a handful of other places. That's it. We need to be masters of the water and the fluids of the body. If I learned that early on, that would have been huge.
That's pretty cool. Question number 4. What is one thing you would like to be remembered for? The legacy.
I think breaking down the licensure barriers of learning in this country. That's like one of my things that we should all be, whether we're a DC or a PT or a fill in the blank ABC, none of that matters. We're all studying the same human performance, body, biology, physiology. Like, we all need to be helping each other and have the same similar foundation. Now, that doesn't mean everybody's got to learn to manipulate, but this is what I teach my students. If you're here and if you're not a DC and you're not manipulating, then you want to be in this paradigm, you better go partner up and find a good chiropractor You can't do it without it. Everybody, and that's a rub for me. In schools these days, these kids are getting out and they're not even adjusting.
Mm-hmm.
Everybody's the new soft tissue wonder kid. I'm like, buddy, right?
Yeah.
Like, that's got to stop.
Yeah.
That's not part of my agenda. My agenda is just like, hey, we all need to be studying together. Like, I need to be, involved in PT things, not just chiropractic things.
Question number 5, and the final question for our rapid fire questions is simply, what is your favorite exercise?
What is my favorite exercise? Boy. Man, I think the biggest can of worms one, which I'll leave for the last one, is a true proper body weight squat. We use the squat as the ultimate complex coordination between the pelvis, the hip, the knee, the ankle, and the foot, and the spine and the head and the scapular girdle.
Wow. Love that. Love it.
And most people can't do it with just body weight properly.
That is fantastic.
Yeah. I wanted to say it earlier because when you first started this podcast, you said something about, we can go down that can of worms. I've been wondering what the hell the can of worms was.
Going down that path. Hey, it's just that the pelvis is the center of the fascial connectedness universe of the body.
Interesting.
And that means if a headache comes in, you go to the pelvis. If an ache comes in, you go to. Everything is linked to the pelvis. The TMJ is only 3 connections away from my pelvis. It only takes 3, and I've already messed up my TMJ.
Wow, interesting.
So that's the can of worms, is like the pelvis. And the pelvis, unfortunately, in a lot of the world, is like still, it barely moves. What's that guy talking about? He's selling you a hill of beans. All these researchers, all these people on Instagram. Is your doctor telling you your pelvis is out of place? It's like, if you had any clue what that outflare, that ilium problem with the hamstring and the downstream consequences of that truly are, I mean, come on. Like, you can't even argue with that.
Fantastic.
So true. You have a background also, among all your other stuff, in strength and conditioning, as well as injury prevention. How do you integrate that strength and conditioning along with the holistic approach for increasing athletic performance?
I mean, I really have handed that off to people that spend their life doing strength and conditioning. When I made the turn, I did the strength and conditioning and training, helping myself financially put myself through chiropractic school. And that was a great place because you got to understand all that stuff, and I can talk the language, and now I got the letters and all that stuff, so I can talk to a trainer. But ultimately, when they get to a certain point in the post-surgical return to play process, there's people that are way better than that than me. But we set the foundation. We set the foundation with all these proper, segmental capability is really what I'm after. I'm after the post-injury. Does all parts of the glute med work well? Does all parts of the glute max work well? Does everything fire when it's supposed to? And then if you want to go train them and run them around, that's fine. If everything's been done on the front end, shouldn't have any problems. If everybody knows their job.
Yeah, fantastic. All right, we're gonna end with this question here. It's more of your personal perspective, but looking forward into the future and what emerging trends or technologies do you actually see that might shape the future of our manual medicine or manipulation
modality wise?
Yeah, how do you see our profession in the future, or the concept of our treatment approaches for musculoskeletal disorders?
I mean, I think that this newfound interest in fascia, which is at its infancy stages in this country, in my opinion, to the likes and help of Tom Myers and others, but we're 100 years behind the Europeans. They were talking about fascia and this fluid and stuff because Andrew still started it all.
Yeah, interesting.
And that is, we're going to keep going through this process of an evolution of dissection and other things, which, depending on who you do dissection with, that carries its own set of pluses and minuses, not because of the skill of the actual dissection person, but because of how they prepare the body. If you're using, unfortunately, chiropractic school examples of the body that lasts for 6 months and everything's dry and desiccated, you walk away from that body going, oh, I just need to treat it with a little bit more mustard, But if you study dissection with some of these people around the world that are understanding, like, we want this thing to be as close as we possibly can to be right when they drop dead.
Right.
Then you don't put any chemicals in them, and you only refrigerate them, and they only last for 7 days, and you better get to work, because that is what's walking into your office.
That's right. Yeah.
Not the other kind.
Right on. You're right.
Yeah.
It's fantastic. Well, I'll tell you, this has been an extraordinarily wonderful, informative show. Thank you so much, Dr. Jason.
Thank you for having me, guys.
More than that, we look forward to seeing you next week in Vegas.
That's right. That's right. We'll see you in Vegas.
Yeah, man. Thank you.
Thank you very much, Doc. We appreciate it.
Thank you. Thanks for having me. I appreciate it.
Thank you for listening to today's episode of the Crackin Backs Podcast. We hope you enjoyed it. Make sure you follow us on Instagram at Crackin Backs Podcast. Catch new episodes every Monday. See you next time.